Welcome to our video on platelet physiology and thrombocytopenia. Let's begin. In this video, we will discuss normal platelet physiology and thrombocytopenia caused by immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, and heparin-induced thrombocytopenia. For each of these conditions, we'll talk about the pathophysiology, clinical presentation, diagnosis, and management. In this subsection, we will discuss the normal platelets, and we will briefly review the general signs and symptoms of platelet dysfunction. Platelets are not actually cells. Rather, they are cytoplasmic fragments without a cell nucleus which aid in blood clotting. They form by budding off of large cells called megakaryocytes in the bone marrow. Platelets are also known as thrombocytes. When subendothelial collagen is exposed at a site of vascular injury, von Willebrand factor on the collagen binds to platelets and begins to form a platelet plug. This process is known as primary hemostasis because it is the first step that occurs in the clotting process. Let's talk about primary hemostasis now. First, at the bottom of the image, you'll see subendothelial collagen exposed at a site of endothelial damage. Von Willebrand factor is a glycoprotein that binds subendothelial collagen directly and binds to platelets via another protein known as GP1b. This binding process between platelets and endothelium is called adhesion because platelets are adhering to the wall at the site of injury. The two platelets shown here are connected to one another via a third glycoprotein known as GP2B3A. Binding between two platelets is known as aggregation. Both adhesion and aggregation are essential for formation of a platelet plug. A 45-year-old man is brought to the emergency department due to an accidental laceration on his left index finger from a steak knife. He is bleeding from the finger, but he is hemodynamically stable. Pressure is applied to the wound, and the finger is wrapped with gauze. After several minutes, the bleeding stops. The physician explains to the patient that bleeding was stopped by cells called platelets. How do platelets aid in blood clotting? The more simple answer to this question is that platelets form a platelet plug at the site of injury. The more in-depth answer is that platelets bind von Willebrand factor on subendothelial collagen at the site of endothelial injury. This is known as platelet adhesion. Additional platelets then aggregate by binding to each other via GP2B/3A receptors. This aggregation of platelets then forms the platelet plug. As mentioned earlier, platelets are required for primary hemostasis, or the first step of blood clotting. Thrombocytopenia is defined as a platelet count less than 150,000 platelets. Qualitative platelet dysfunction, on the other hand, is characterized by normal platelet count but diminished platelet activity. Both thrombocytopenia and qualitative platelet dysfunction present as an inability to stop initial bleeding due to defective primary hemostasis. This commonly presents as mucosal bleeding, such as nosebleeds, which are also known as epistaxis, bleeding gums, menorrhagia, or GI bleeding. Patients may also have spontaneous bleeding into the skin, which presents with petechia or purpura. A petechia is bleeding in the skin with a diameter of less than 3 millimeters, while purpura is bleeding in the skin with a diameter between 3 millimeters and 1 centimeter. Spontaneous bleeding is likely with a very low platelet count, typically less than 20,000. Patients with milder thrombocytopenia will often present with nonspecific symptoms such as easy bruising. Here you can see an example of petechia, which are punctate lesions from capillary bleeds commonly seen in people with platelet disorders. These lesions will be non-blanchable, which means they will not change color when pressure is applied. Let's start with immune thrombocytopenic purpura. Immune or idiopathic thrombocytopenic purpura is thrombocytopenia due to autoantibodies directed against the GP2B3A antigen on platelets. Antibody-bound platelets are then sequestered and destroyed by splenic macrophages. Primary immune thrombocytopenic purpura is the most common form of the disease, and it is idiopathic. Secondary ITP results from a trigger, such as an underlying autoimmune condition like systemic lupus erythematous, or infections like a viral upper respiratory infections, HCV infection, HIV, or a drug reaction. Mild immune thrombocytopenic purpura with a platelet count more than 50,000 can be asymptomatic or present with easy bruising. In contrast, moderate or severe ITP with a platelet count less than 50,000 presents with skin and mucosal bleeding, namely petechia, purpura, epistaxis, and hematuria. ITP can also present with GI bleeding and menorrhagia. Immune thrombocytopenic purpura is a diagnosis of exclusion. In other words, one should exclude all the other possible causes of thrombocytopenia before one can diagnose a patient with ITP. A complete blood count will show thrombocytopenia with a platelet count of less than 100,000. A peripheral smear typically shows normal-sized platelets. However, they might be slightly large due to overactive megakaryocytes, sending out immature platelets in the blood. Bleeding time is the time it takes to stop bleeding by primary hemostasis. Bleeding time is completely dependent on the normal activity of platelets. Therefore, it is increased in thrombocytopenia as well as in qualitative platelet dysfunction. Prothrombin time, PT, International Standardized Ratio, INR, and partial thromboplastin time, PTT, depend on coagulation factors and secondary hemostasis. Therefore, an isolated platelet disorder typically does not change any of these parameters. Inflammatory markers like C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, can be measured to look for inflammation. Finally, we should test the patient for those chronic viral infections such as hepatitis C and HIV, implicated in some cases of ITP. Management of immune thrombocytopenic purpura depends on the patient's age. In children, isolated skin findings require observation. However, if bleeding is evident in other organ systems, then one can administer steroids, intravenous immune globulin, IVIG, or anti-D immune globulin, while steroids suppress the production of anti-GP2B/3A antibodies. Intravenous immune globulin and anti-D immune globulin saturate antibody receptors on splenic macrophages, preventing platelet destruction. In adults, we prefer observation if the patient has isolated skin findings and the platelet count is more than 30,000 cells. If there is bleeding in other organ systems, or if the platelet count is less than 30,000, then we can administer the same medications that we discussed for children. Now we will move on to thrombotic thrombocytopenic purpura. TTP is thrombocytopenia due to a deficiency in ADAMTS13. ADAMTS13 is a metalloprotease that cleaves von Willebrand factor multimers into monomers. In the absence of ADAMTS13, uncleaved von Willebrand factor multimers cause overactivation of platelets and formation of platelet microthrombi. In rare cases, thrombotic thrombocytopenic purpura can be inherited. However, it is more commonly due to acquired autoantibodies against ADAMTS13. Platelet microthrombi cause platelet consumption, leading to thrombocytopenia and bleeding. Additionally, these microthrombi can occlude small vessels and lead to shearing of red blood cells, causing a microangiopathic hemolytic anemia. Vasoocclusion by microthrombi can also lead to end organ damage in the kidneys and brain. As we already discussed on the previous slide, thrombotic thrombocytopenic purpura causes hemolytic anemia and thrombocytopenia. In fact, these two features are essential to diagnose TTP. Additionally, thrombotic thrombocytopenic purpura presents with fever due to a generalized inflammatory state. Renal failure occurs due to platelet microthrombi obstructing renal vessels. Acute renal failure can present with an acute metabolic acidosis due to the retention of organic acid. It can also present with electrolyte imbalances. Finally, TTP is notorious for causing neurological defects like altered mental status or seizures. Let's move on to the diagnosis of thrombotic thrombocytopenic purpura. A complete blood count will reveal anemia and thrombocytopenia. Additionally, we will have laboratory evidence of hemolysis. Hemolysis is typically accompanied by increased lactate dehydrogenase because this enzyme is released into plasma from destroyed red blood cells. Additionally, haptoglobin will be low. Haptoglobin is the plasma protein that binds to free hemoglobin and transports it to the spleen. Indirect bilirubin is high due to hemolysis-induced bilirubin production. A peripheral smear will reveal schistocytes. Schistocytes are fragmented red blood cells caused by shearing forces. In TTP, they are formed when red blood cells come into contact with the platelet microthrombi. Finally, since there is thrombocytopenia in this condition, bleeding time will be increased. However, the prothrombin time and partial thromboplastin time will be normal because the coagulation cascade is not activated in thrombotic thrombocytopenic purpura. This is in contrast to disseminated intravascular coagulation, where the coagulation cascade is activated and the PT and PTT are also increased. Disseminated intravascular coagulation, DIC, will also present with thrombocytopenia, increased bleeding time, and schistocytes on smear, but PT and PTT will help you differentiate TTP from DIC. Here you can see a peripheral blood smear showing schistocytes. Schistocytes are these fragmented red blood cells, which look like helmet cells. Let's talk about the management of thrombotic thrombocytopenic purpura. If TTP is suspected, treatment should be started immediately without waiting for lab results. The first-line management for TTP is emergent plasma exchange. Plasma exchange removes the anti-ADAMTS13 antibodies and repletes ADAMTS13 levels from the donor plasma, allowing cleavage of von Willebrand factor multimers. Additionally, steroids or rituximab can be added to suppress the anti-ADAMTS13 antibody production. A 26-year-old woman is brought to the emergency department due to generalized tonic-clonic seizure that occurred 1 hour ago. She is febrile and anuric. The complete blood count reveals anemia and thrombocytopenia, while peripheral smear shows fragmented red blood cells. What is the next best step in management of this patient? This febrile patient has neurological dysfunction manifested by generalized tonic-clonic seizure. She also has an acute kidney injury evidenced by anuria. Additionally, the complete blood count reveals anemia and thrombocytopenia, while the peripheral smear shows fragmented red blood cells. These fragmented red blood cells are schistocytes. All these findings point toward the diagnosis of thrombotic thrombocytopenic purpura. The next best step in management of a patient with thrombotic thrombocytopenic purpura is emergent plasma exchange. Let's move on to hemolytic uremic syndrome, or HUS. Hemolytic uremic syndrome is most often caused by the Shiga toxin that is produced by E. coli. This strain belongs to enterohemorrhagic E. coli, EHEC species. Shiga toxin is thought to have direct toxic effects on renal cells, specifically the endothelial cells in the glomerulus. This leads to acute kidney injury. The toxin also induces a procoagulant state, leading to microthrombi and consumption of platelets, leading to thrombocytopenia. Atypical HUS is a rare disorder characterized by uncontrolled activation of the complement system. Most cases of atypical HUS are caused by autoantibodies to complement factors or a genetic mutation in the complement protein itself. Hemolytic uremic syndrome, or HUS, presents like a mild version of thrombotic thrombocytopenic purpura. The key clinical findings include a preceding history of bloody diarrhea due to enterohemorrhagic E. coli, hemolytic anemia, thrombocytopenia, and fever. Compared to TTP, HUS typically has severe kidney injury but mild neurological dysfunction. As you can see, the diagnostic findings of hemolytic uremic syndrome are identical to those of thrombotic thrombocytopenic purpura. A complete blood count will reveal anemia and thrombocytopenia. Hemolysis will be evidenced by increased lactate dehydrogenase, LDH, low haptoglobin, and increased indirect bilirubin. Additionally, a peripheral smear will show schistocytes. Finally, bleeding time will be increased while PT and PTT will be normal. Management for HUS is primarily supportive. The most important step, as with any diarrheal illness, is hydration. Blood transfusion may also be indicated if anemia is severe. If an acute kidney injury is not improving in response to hydration, dialysis may be needed. Although most cases of HUS are secondary to an E. coli infection, antibiotics should not be given. Let's recall that this is not the bacteria itself that triggers HUS, but the toxin it produces. Antibiotic therapy will destroy more bacteria, releasing more toxin into the blood. This will further exacerbate patient's overall status. A 12-year-old boy comes to the physician due to decreased urination for the past 2 days. He ate burgers at his friend's party 5 days ago, and he noticed blood in his stool afterwards. He has been having 8 bowel movements per day. The patient is febrile, anemic, and thrombocytopenic. His blood, urea nitrogen, and creatinine are elevated. What changes are expected in coagulation studies of this patient? This febrile patient has had bloody diarrhea after eating burgers. This presentation is suspicious for enterohemorrhagic E. coli infection. He is anemic and thrombocytopenic. Additionally, his blood, urea nitrogen, and creatinine are elevated. All these findings suggest the diagnosis of hemolytic uremic syndrome after E. coli infection. Thrombocytopenia in this condition increases bleeding time. However, the prothrombin time and partial thromboplastin time will be normal because the coagulation system is not affected in hemolytic uremic syndrome. Let's move on to heparin-induced thrombocytopenia, or HIT. There are 2 types of HIT, type 1 and 2. Type 1 heparin-induced thrombocytopenia is more common, and it is the non-immune activation of platelets by heparin leading to platelet microthrombi. Type 2 HIT, on the other hand, is an immune phenomenon. It is caused by IgG antibodies against the heparin platelet factor 4 complex. This antibody causes platelet activation and microthrombi formation. In type 1 heparin-induced thrombocytopenia, the symptoms start 1 to 4 days after starting heparin. In type 2 HIT, Symptoms start either 5 to 10 days after starting heparin for the first time, or within 1 day if the previous heparin exposure was in the last month. Patients with heparin-induced thrombocytopenia, especially type 1, can be asymptomatic. However, they can also present with mucosal and skin bleeding, venous and arterial thrombosis, and necrotic skin lesions at the heparin injection site. The gold standard confirmatory test for the diagnosis of heparin-induced thrombocytopenia is a serotonin release assay. Additionally, the platelet count in type 1 HIT is usually greater than 100,000 cells, while it is greater than 20,000 in type 2 HIT. Finally, type 2 HIT is characterized by more than 50% reduction in baseline platelet count. Management for heparin-induced thrombocytopenia is to stop all heparin products. Additionally, since patients with heparin-induced thrombocytopenia are in a hypercoagulable state due to platelet microthrombi, one should initiate a direct thrombin inhibitor like dabigatran or argatroban. We can also use fondaparinux. Here's a table summarizing all the concepts that we discussed for type 1 and type 2 heparin-induced thrombocytopenia. A 35-year-old woman presents to the emergency department due to sudden shortness of breath and bloody cough. CT pulmonary angiography reveals a filling defect in the left pulmonary artery. She is diagnosed with pulmonary embolism and treated with IV unfractionated heparin. 6 days later, a complete blood count shows a platelet count of 70,000. Her initial platelet count was 210,000. The physical exam shows necrotic skin lesions at the heparin injection site. Her vital signs include a temperature of 36 degrees Celsius, blood pressure of 125/75, and heart rate of 85, and respiratory rate of 15. Which of the following is the best next step in the management of this patient? A. Continue heparin. B. Stop heparin with no further treatment. C. Stop heparin and administer dabigatran. D. Stop heparin and administer warfarin. This patient is diagnosed with pulmonary embolism, and she's treated with IV unfractionated heparin. 6 days later, her platelet count has decreased from 210,000 to 70,000. This is more than 50% decline of the baseline platelet count. The physical exam shows necrotic skin lesions at the heparin injection site. Therefore, this patient is most likely experiencing type 2 heparin-induced thrombocytopenia. The next best step in management of this patient with presumptive diagnosis of heparin-induced thrombocytopenia is to stop heparin and administer either direct thrombin inhibitors or fondaparinux. Since dabigatran is the direct thrombin inhibitor, the correct answer is C. Let's discuss why the other options are incorrect. Option A is incorrect because all types of heparin should be discontinued in the patient with presumptive diagnosis of heparin-induced thrombocytopenia. Option B is incorrect because heparin-induced thrombocytopenia is a thrombotic disorder and it needs anticoagulation with either direct thrombin inhibitors or fondaparinux. Finally, option D is incorrect because warfarin does not work immediately after administration. Additionally, it induces an initial prothrombic state. And that concludes our lecture on thrombocytopenia.